graduate scholarship. She has published multiple journal articles and textbook chapters on prostate imaging and intervention, and is a member of numerous clinical societies. In 2014, she founded the International Laser Network to bring together international experts on laser focal therapy to create a dedicated educational forum for sharing of experiences and techniques and for harmonizing data collection intervals and patient-reported outcomes. A vocal patient advocate, she has been active in patient education and awareness for much of her career, working with us through international zero cancer and local prostate cancer support groups. Ms. Greenwood, thank you so much for coming all the way here, and so to you. Thanks very much.
Thank you for picking me up in a thunderstorm to get me here. It's always a privilege to be able to talk to patients and their partners and their caregivers, because while we know the internet is a wealth of information, it's also a wealth of misinformation. So I want to make sure that anybody who's even remotely considering focal therapy understand what it's all about, how it works, the efficacy, the safety, etc. So with that, let's get started. I have nothing to disclose. In other words, I don't get paid by vendors, I don't get paid by pharma, I don't get paid by anybody that does medical imaging. I'm a grad student right now and a graduate of the University of Edinburgh. And I always say nice things about them, but they don't pay me to say it. And I don't have a mic on, but I have 4 kids, so I'm kind of loud, I project. So if somebody can't hear me, raise your hand and I'll talk loud. So what we're going to talk about today is the history of biopsy strategies, evolution of multiparametric MRI, technical aspects of MR-guided biopsy, the rationale for MRI-guided laser focal therapy of prostate cancer, and an update on NCT 02243033, which is a phase 2 clinical trial. Phase 1 is over, so you understand how the phases of clinical trials work. Phase 1 is, did we kill anybody? And the answer to that was no, which is good. So then we move on to phase 2, and we ask the question, how are we doing? Are we non-inferior to the gold standard, and are we helping? Okay? So another thing that I do in my free time is I work with government agencies. I've sat on expert panels with the folks on the U.S. Preventative Services Task Force, written papers with Dick Ablin, who's the guy who invented the PSA. I talk to our governors, our senators, and I let them know that prostate cancer is a threat. I mean, people say, oh, more men die with prostate cancer than of prostate cancer, but don't say that to a guy who's dying of prostate cancer, right? So we've got to figure out what's going on with this disease. Much of it stems from a gold standard that's been in place for 3 decades. When I look at breast MRI, and that was my original nickname, was the breast lady. Now I'm the prostate lady. I don't know which is more flattering, but my most impactful work, I thought, was in developing a MRI software system to help with biopsy in the MRI system. So I joined a company called Invivo back in 2005 to help them commercialize this breast coil and this software system that was integrated with multiple vendors to be able to do in-bore MR-guided breast biopsy. Made great sense. Then once that thing was commercialized, my GM came to me and said, can you take everything you know about anatomic, morphologic, quantitative imaging of breast cancer, interventional planning and reporting, and move it from up here to down there? And I said, sure, let's do it. So just like breast MRI, prostate MRI complements the gold standard. It doesn't replace it. It's an additional tool in the armamentarium to make sure that you're not being sent down the path to destruction, right? When we look at what a trust biopsy is, you've got a person in an office with an ultrasound transducer in the rectum. They see an outline of the prostate gland, or maybe even a high-res image of the prostate gland, but there's very little to target. So it's 6 cores off one side, 6 cores off the other side, which I nicknamed poke and hope. You know, I told Jim I could throw chicken bones on the floor right now and tell you better than a trust biopsy what's actually going on. Can it give you a clue? Sure. So we'll talk about this a little bit more in a minute. But my philosophy is long been, if it looks like a skunk and it smells like a skunk, it's probably a skunk. If we could see it on MR, we could target it with biopsy. We could use that targeted tissue for Gleason scoring, histology, and we can also use it for genomic testing, right? And then if we could get at the tumor in MRI for biopsy, why not convert that biopsy system to a therapy delivery system? I'm not that smart, but that makes sense to me. So let's look at what's happened with prostate biopsy over the years, from the 1920s and on. Back in the 20s, they would do an incision in the perineum, poke around and feel, and then stick a needle in things that felt funny. Ouch. And then in the 30s, they thought, well, let's stick a stainless steel tube down the urethra, and then poke around with a finger in the rectum, and then take samples out of the posterior part of the gland. Then in the 60s, Watanabe-san and his team in Japan came up with the first clinically useful ultrasound images. At that same time, McNeil et al. Described zonal anatomy of the prostate. So whether I'm an imager or a surgeon or an oncologist or a pathologist, when we talk about where's the tumor, everybody's talking about the same thing in terms of where it lies. Using known anatomic references, we could talk about central zone, transition zone, peripheral zone, anterior fibromuscular stroma, etc. Then in the 80s, we had these great things. These are ultrasound wands called transducers. So these intracavity transducers are really good for, in ladies, transvaginal ultrasound, so we can see the ovaries really well, and in men for transrectal ultrasound, so we can see the prostate a little better. And then I mentioned Dick Ablin invented the PSA test, which was approved by the FDA for screening for prostate cancer. And Hodge et al. Came up with a sextant biopsy schema, which is simply popping out 3 cores from each side of the gland, and again, poke and hope. But it's all they had back then, so I forgive them. It's not like these are bad people or stupid people. They did what they did in terms of medical progress to bring us to where we are today. So now, in the 1990s, Stamey and Eskew said, well, if 6 is good, 18 or 24 must be better. So instead of just taking the red, they take the red and the blue, or the red and the green, or the red, the blue, and the green. But the problem is, what if it's here, or what if it's here, or what if it's here? You're still missing, even if you do systematic extended course. Then the philosophy of, well, if we can't get it with that, let's do saturation biopsy. Put a perineal plate up on the guy's crotch, and then sample every 3 millimeters over the entire gland. So I'm going to tell you guys a funny story. I tell this every time I do a patient advocacy meeting. You've got to be nice to everybody because you never know. So Dr. Tom Plasek from Duke gave me his slides about saturation biopsy so that I could explain it and what it looks like. So about 8 years ago, I get this invitation to the 3rd International Workshop on Minimally Invasive Ablative Therapies of Kidney and Prostate Cancer, and I open the brochure and I see that he's the chair of the meeting. And I'm like, oh my God, that guy tried to kill me when I was 12. So I Googled him, it was him, and I opened up my email and I'm like, Dear Tom, always wondered what happened to you after 7th grade. I see you became a urologist, great job. It's been 35 years since you grabbed me by the ankle in the Hillcrest Junior High School swimming pool during gym class and tried to drown me. But it's a good thing I don't hold a grudge, I'll see you at the meeting. So I hit send, despite my better judgment, I hit send, and like 5 minutes later the phone in my office rang, and it was him. And he's like, yeah, about that. So anyway, now he shares his slides with me. So this is courtesy of Dr. Plasek, and it shows just all the equipment that you need to do a saturation biopsy. And those of you who are non-medical imaging people, I want you to look carefully at the reflection on this monitor. See the hands? So there's the transducer going in the guy's butt. There's the gloved hands of the person doing the procedure. This is the image of the transducer in the rectum with the needle sheath aiming at the prostate. This oval thing here is the prostate. This is the inferior wall of the urinary bladder. The black stuff is pee. So the guy's head is over here, his feet are down here, and we're looking at the transducer going in with the needle guide popping out cores from what? The prostate, but what in the prostate? I mean, in some guys, this thing is, 120 grams. If you're taking out 12 cores out of a 120 gram gland, well, how do you know what the heck you're getting? So, my point. And then Mr. Mann is in here, we do ABC, 1, 2, 3, I sunk your battleship, and we end up with this. So the minute somebody argues with me about the cost of MRI I talk about the cost of this, because these are $200 a cup, $200 to $300 for a pathologic evaluation. So if we can head things off at the pass, do imaging prior to biopsy, we can actually target things that maybe make sense and do less cores, less punctures, less risk of infection, less bleeding, right? And when people say to me, when I worked in vivo and I was putting together the marketing material for the MRI biopsy system, and I said we have the potential, the great potential, to reduce blood loss, to reduce infection, and to reduce pain. I had a lawyer call me from Latham, New York, and go, Bernadette, how can you make such a claim? I said, I have an idea. You get on a plane and you fly over here, and I'm going to stab you twice in one arm, and I'm going to stab you 18 times in the other arm. And you tell me if what I said makes sense. The other good thing was the literature showed that when we went to this extended scheme for taking more cores, the rate of hospital admissions and sepsis went up in parallel. So I'm no rocket scientist, but I figure if doing more cores increases infection and hospital admission, maybe doing less cores will reduce infection and hospital admission. But again, I'm no genius, so. And I love this because this is like saturation biopsy. I mean, you just go in there. I've got guys who've had 40, 50, 60 cores, come back negative, we do an MRI and then see the thing clear as day, stick a needle in it, and boom, answer the question. And why does this work? Well, because when we do an MRI, we're able to see anatomic and morphologic information depending on what pictures we take. The pictures are called pulse sequences. We run these experiments in the MR scanner, and each pulse sequence reveals something different about the tissue under scrutiny. So this is an ultrasound image, and this is an MR image, an anatomic MR image. Which image would you want guiding your biopsy? Right. And so when we look at the National Comprehensive Cancer Network guidelines, back in 2009, it was repeat bad test after repeat bad test after repeat bad test without addition of imaging. Then finally in 2012, multiparametric MRI was mentioned for the first time in the NCCN guidelines. The ESUR guidelines in 2012 were published, and that's where the PIRADS committee was born. I'm a member of the PIRADS Prostate MRI Accreditation Committee, as well as the PIRADS Protocol Optimization Subcommittee. My degree is in imaging science, so I'm not a bad guy to have on the committee.
So Dr. Byrne was on that committee?
She's on one of them, yeah.
I wanted you to say at the slide.
Right. Dr. Verma is a friend and colleague of mine at University of Cincinnati. She's amazing.
Sure.
So what is PIRADS? So PIRADS is prostate imaging reporting and diagnosis system, and it's a range of scores 1 to 5, scary looking, not so scary looking, and everything in between. I've been petitioning for years that we change this language, because when patients look at this on a report, they think, oh my God, I have cancer. PIRADS 5 lesions can be inflammation or infection. It's not always malignancy. So I think the language should be changed to highly recommend biopsy, probably should biopsy, intermediate need for biopsy, probably don't need a biopsy, definitely don't need a biopsy. See, that makes it action-oriented rather than diagnostic. See what I'm saying? But that's just my personal opinion, and hopefully I have the right form to get the change made. So PIRADS version 2, it's about, if it looks funny here, and it looks funny here, and it looks funny here, you should probably stick a needle in it. I talked to you about pulse sequences and what they show. So there's something called a T2 weighted image that's anatomic and morphologic, and it shows nodules, and it shows the anatomy of the gland. Then there's something called diffusion weighted imaging, high B-value diffusion, and apparent diffusion coefficient maps. So Einstein, in the Miracle Year, talked about something called Brownian motion, which is water molecule movement in normal tissue. So all of us have water moving through our bodies, between tissue all the time. But in the setting of infection, inflammation, or malignancy, guess what happens? Water doesn't move so much. It's like stuck in concrete blocks, and it doesn't go anywhere. So we've got ways to image that lack of water movement and to quantify it with something called an ABC value, or apparent diffusion coefficient value. And we'll talk about that a little bit more. And then there's always MR contrast, that we can see perfusion and watch it go in and out. So, in this guy, it looks funny on T2, it's dark on ABC, it's bright on high B-value, and it perfuses wildly. Yeah, you should stick a needle in it, right? Do we also want to go sample all over town? There's different schools of thought on that. I'm a minimalist, and part of our protocol is reliance on imaging. So what we don't want to do is rely on imaging, but oh, by the way, go behind and do 12 random cores for grams, you know. We have excellent software that allows us to segment the gland, to do perfusion, to put color overlays. Now, when you look at this image, you'll see all kinds of stuff enhancing and, you know, all this weird looking stuff. They say in imaging, safety and symmetry, anything bilateral and symmetric is usually, you know, your mama gave it to you, don't touch it. This is prostatitis. And then in here, all this nodular stuff is BPH. Then this one little thing right here was the cancer. And it's kind of cool because the software can show me the lowest ADC of that whole volume, and it is the cancer. And I know this because we biopsied. This is 2009. This was the first patient that we did, and it was a great teaching case because it showed what prostatitis looks like, biopsy proven, what BPH looks like, biopsy proven, and what a lone unifocal unilateral cancer looks like. So this is a really good tool. I mean, urologists shouldn't be threatened by this. They should be grateful for it because we've got patients that have had multiple trust biopsies over 3, 4, 5, 6, 7 years. Negative, 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 negative. Order the MRI, boom, there it is right in the front where you're never going to reach with a trust biopsy gun, and we get it. And, you know, instead of being viewed as the heroes, we're viewed as the antagonists or the enemy. It's kind of strange, but anyway. Version 2 of the NCCN guidelines in 2016 state very clearly, multi-parametric MRI followed by lesion targeting may maximize detection of high-risk disease and limit detection of low-risk disease. We don't want to see every little distal thing. Picture a pepper grinder, okay? And let's say all the horns up top are cancer. If you've got what's called sparse pattern 3+3 and there's little flakes all over the place, nobody cares. They're not going to do anything with it. Low volume, low grade disease generally does not metastasize and isn't considered lethal. That's why guys go on active surveillance for 3+3. If it's truss detected 3+3, that's a little bit of a mask because we don't know what it really is because nobody imaged and nobody targeted. So what we aim to do is find those big things. If it's little bitsy sparse stuff that MR doesn't pick up, only 3 to 8% of the time is it something clinically significant. Where when you look at trust biopsy, they miss clinically significant disease like 47% of the time. So every time I get a urologist in my face saying, oh, but you guys missed 3 to 8% of clinically significant cancers. Well, that's certainly better than 50%. And when we look at the research that's been done, this is 2006. This is well over a decade ago. Radboud University Nijmegen in the Netherlands proved that we have an area under the receiver operating curve of around 91% when you combine these pulse sequences to evaluate prostate cancer. Okay? The Yale team repeated that same study 10 years later in 2016, and they're up to a negative predictive value of 96%. What does this mean? A negative predictive value is when we do a test to rule out a disease, and the test says you don't have it, we're right. That's negative predictive value. That's a really important thing. So any guy going for MRI who gets a report back saying no suspicious lesions detected, he can probably sleep good at night. There's a high likelihood he doesn't have anything bad. So what do? You do PSA every 3-6 months, and you repeat MRI 6-12 months later. If anything changed, you stick a needle in it and figure it out. It's a stepwise progression, and I always say, you know, dominoes have to fall. You know, before I see a guy jumping up and down saying I want focal therapy, I have to make sure that we've had a target biopsy, because as much as we want to treat guys who should be treated, we don't want to treat guys who have no business being treated. So we talked a little bit about ABC maps and what they mean. So there's this inverse linear relationship between ABC value and aggressiveness of disease. When you look at these pictures, you can see something unifocal that's kind of light gray. The ADC is pretty high, 1240. This one's 990, and this one's, I'm blind, lower. Let's say it's lower. But then look here. So you've got a 3+3 that correlates with that, a 3+4 that correlates with that, and a 4+5 that correlates with that. So the lower the ADC and the darker the diffusion, the higher grade the disease. That's like the general understanding. It's not like a hard, fast rule, but it is a general understanding that the lower the ADC, the worse the disease. So let's talk about targeting again. So we've got a little lesion here. We can see it on another sequence. We can see it over here on high V value. Now, and it's also perfusing, like I showed you before. When we look at where we're going to aim the biopsy gun, aiming it right there is the area of ADC that's 691. You move that cursor just a couple of voxels, look at what the ADC is now. Do I want a specimen from here or a specimen from here? Right, so when we do truss biopsy, we're going pow, 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 pow. If we're lucky, we might get a little piece of this. We don't know where that needle fell. There's absolutely no way to prove it. In a court of law, when we do our biopsy, we can show exactly where the tissue came from. So the other problem with truss is the throw of the gun. In a big gland with a big, huge cancer that you shouldn't miss at all, this guy had negative biopsy year over year because of the lack of reach of the gun. Okay, so that's the biggest problem, is missing clinically significant disease. The other thing is potentially picking up something inconsequential. If we pick up prostatitis or Gleason 3+3, meanwhile there's a 4+4 over here, or if we skim the edge of something that's got an aggressive component, but it's got some low grade at the edge. These are all big confounding factors for truss biopsy. It's why we insist on imaging. It's not, oh, we want to make money, or oh, we want to do, it has absolutely nothing to do with that. It has to do with, in any other procedure, if you had a brain tumor and they were going to biopsy your brain tumor, what do? They take a picture. If I have a breast tumor and they want to biopsy my breast, no woman in this room would stand for somebody saying to you, oh, we're going to put 20 random needles in your breast to try to find your cancer. And if we can't find it, we hope it grows bigger next year and we pick it up. Isn't it lunacy?
Yeah.
So, Tom Hambrock, a colleague of mine from the Netherlands, presented this 8 years ago at the Society for Computerized Body Tomography and Magnetic Resonance. He won the Lauder Award for comparing MR-guided biopsy to 10-core truss biopsy. I mean, no doubt what technique picks up clinically significant disease better.
Are you taking questions at all?
Of course.
On that previous slide,
Sure.
when it said Gleason greater than 7, where did the 7 come from? From the truss biopsy or from the prostatectomy?
I believe that he did whole mount histology for all his comparisons on both of these cohorts. So he had whole mount when he compared the MR-guided biopsy to the random truss. And
Okay, so in other words, the prostatectomy, the blue bar, did...
No. This isn't prostatectomy. The blue bar is 10-core biopsy.
I'm sorry.
The blue bar is 10-core random biopsy.
Okay.
It only picked up around 50% of Gleason 7s and higher.
Okay, but the Gleason 7 is, that result is from the...
Whole mount histology.
Okay.
And then MR, when you compare how many Gleason 7s it picked up or greater, were more around 90-something.
So for those patients, they were actually telling them if they had the biopsy done that they actually had a Gleason score of less than 7?
In these patients, these ones have
No,
less
I'm talking
than
about
7.
in the right hand there.
No, this is 7 or greater.
By one method, but the other method, is it still predicting the same amount as well, a Gleason score of 7?
So let me explain it this way. The patients were recruited knowing they were going for prostatectomy, and they had had their biopsy already, and then the whole mount was compared to their biopsy results. So any man who had true Gleason 7 or greater at surgery was put in these buckets. In other words, 10-core biopsy missed half the clinically significant cancer. Does everybody understand that? Okay. And then these are just some papers talking about transrectal MR-guided biopsy and the results. I know that you all have a bibliography and a lot of other resources, but those are some really good papers. So what it looks like for the patient, he lays on his stomach, we put a little needle guide in his rectum. It's smaller than my index finger. It gets popped in with some viscous lidocaine to reduce any discomfort. And then we use a software program that shows us where the needle guide is in the patient's rectum. We localize the tumor, and then the computer gives us the offsets that we need to angle left, right, front, back, and head, foot, so that we can achieve the right trajectory to take the piece of the thing that looks scariest.
Can I ask you a really quick one? So what is the accuracy then? Okay, so you have the image, even if
None. So the application requirement specification and the FDA submission had no accuracy claims. This is image guided, so there is no accuracy claim. So in other words, we're getting in the neighborhood and we're relying on imaging to tell us where we are. So before a needle is ever fired, there's a confirmatory image performed to make sure that that trajectory is in fact going through the thing that we want.
Right,
The
so what I'm
computer
asking,
has no accuracy claim.
right, and that's what I'm asking. So let's say you think that you've hit the center of the tumor,
We take a picture of it.
and so you take a picture of the needle in the tumor.
Correct. I'll show you that in a second.
Okay.
So this is a picture of the procedure in progress. When you have a biopsy performed, these little bitty stringy tissue samples are taken out of the tip of the needle. So imagine angel hair pasta. Angel hair pasta is about the same caliber of one of these tissue specimens, and they're on average, 1.4 to 1.8 centimeters in length. Okay, what my goal is to get a tissue specimen that's got a high volume of tumor in it. Like, I want to be shooting all over the place and get nothing, and you don't want to shoot and only get a little tiny piece of it. You want to go right through the biggest, juiciest part of it and get as much of it as possible. That's the only way that you can do treatment planning, right? So our pathologist gets the specimens, cuts and stains them at night, and by the next day I have my prelim path, especially for pre-op patients. The way our reports look is we have bold language talking about the worst of the worst. We have a table that includes the core length, the length of this little stringy piece of tissue that we took out, how long that was, how long the cancer was, what percent involvement of that sample was cancer, and what the Gleason score was, and then any other narrative, cribiform, neuroendocrine differentiation, or whatever. And then we have a photomicrograph as well as an image showing the needle right through. So when I get reports from patients wanting focal therapy and they hand me a trust biopsy report, all I see is X marks on a diagram where the person who did the biopsy thought they went. Sometimes the report will even say muscular tissue or periprostatic fat, like they're not even in the gland. Where are you going? How do you know? You don't. So this is really important to us. Any patient that comes into our clinical trial, we have to have an MR targeted biopsy again, because we don't want to treat guys that we have no business treating. And what is Gleason score?
Question.
Sure.
Oh, I'm just curious, a general question about MRIs. It always lingers in the back of my head, but I don't think about it. You have to go through tissue to get to the prostate gland when you do an MRI. All the pictures I see look like it's wide open, but is there any interference in the tissue of the body from the outside of the body
No.
between there to the prostate gland?
No, it's like brain imaging or knee imaging. It's cross-sectional imaging.
How do they avoid putting the other parts of the body in the picture that's in between them?
There's a field of view that's prescribed, so when you set up the scan, you tell the scanner what area you're looking at and how big the field of view is. And then there's these techniques called no phase wrap, no frequency wrap. So you have phase and frequency directions on the image, and you tell the computer that's doing the scanning not to let the hips wrap into the prostate, not to let the butt wrap into the prostate. So that's just it's a scanning parameter that gets plugged in the scanner. Does that make sense? It's called no fold over. Like, so if I had a piece of paper and I folded it 4 ways onto itself, I can also unwrap it so that there's nothing but what I'm looking at. So it's a digital no fold over.
I figured there's some way of doing it, but I'm just curious.
Yeah, so
The
there's something called
technical-
K-space.
how
When
it
we
works.
make an MRI image, we fill K-space and we deposit information into K-space in multiple directions to create 2 or 3-dimensional imaging. So we're also able to tell the computer at what limits of K-space we don't want anything filled. So it's empty, other than the information that we want in the region that we prescribe. It's 4 years of college to explain the whole thing, but I hope that helps a little bit. But the paper analogy is a really good one.
Mhm. Thanks. It's not important for me to know that. I'm just curious.
Yeah. So in terms of Gleason scoring, the ISUP has new guidelines for grade 1, grade 2, grade 3, grade 4, and grade 5 disease. And I came up with a riddle, when does 4 plus 4 equal 4? When you use the ISUP modified guidelines, where 3 plus 3 is 1, 3 plus 4 is 2, 4 plus 3 is 3, 4 plus 4 is 4, and anything higher is 5. You have the original Gleason criteria, and then you have the modified Gleason. And what you'll notice is that Gleason 3 here looks a little less scary than Gleason 3 here. So it's really important, no matter what we're doing, I want to make sure that the pathologist describes what Gleason scoring system they're using. They should be using the modified version. And Gleason scoring is simply like Skittle sorting. The stuff that doesn't matter and doesn't look scary is a 1 or a 2. The super scary stuff is 5, and then the stuff in between is 3 and 4. Nobody talks about 1 and 2, ever. We talk about 3, 4, and 5. And so if a guy comes in and he has biopsies that go under the microscope and the dominant cell pattern is Gleason 3, that would be the primary Gleason score. If the second most proliferate cell type is Gleason 4, he would be a 3 plus 4 equal to 7. Okay? If another guy comes in and the dominant cell pattern under the microscope is 4 and the secondary pattern is 3, he's also a 7, but he's got a worse prognosis because the higher Gleason score was the primary Gleason grade. Does that make sense? Primary grade plus secondary grade equals Gleason
Is
score.
that the reason why they're changing the scoring now?
Who knows? Why do they do anything they do? So what I want to do is go to an artificial intelligence system, put all my photomicrographs in, take known pathology, and teach something how to reduce inter-observer variability. Because if you take a specimen and you stick it in front of a pathologist at 8 o'clock in the morning, after they've had their coffee, they may call it one thing, and then you put that same thing in front of them at 1 o'clock in the afternoon, they may call it something else. And oh, by the way, if you send it off to Johns Hopkins and John Epstein looks at it, he may call it something totally different. So it's called inter-observer variability or intra-observer variability, which is why I think artificial intelligence in pathology is like long overdue. And I don't want to put pathologists out of business. I love pathologists. I love my pathologists. They're great. But what we need is something that will sift through architectural features that are known and call it what it looks like, and then the human can confirm it or modify it. But that's just a pet peeve. So going back to the study, we've been accruing patients now since 2010. You saw how we do the biopsy, but instead of using a biopsy gun, we put a laser fiber into a water-cooled laser probe, and that goes in the needle guide and heats up the prostate tissue. So this is the Visualize laser system. This is the box that emits the laser. It's a 980 nanometer diode laser that's FDA cleared. We can use a couple different types of fibers with it. When I do tumor board and we talk about what fiber are we going to choose, it's dependent on the size of the tumor, the location of the tumor, its proximity to other important stuff. So we use smaller fibers for tricky things near the urethra or deep down in the apex, and we use bigger fibers for stuff, way out in the transition zone, not near anything important. And you'll notice this is an image of a brain. So in 2009, the biopsy system was commercialized. It won the Medical Design Excellence Award in 2010. I went to my GM and I said, look, if I can stick a needle in something and accurately get a specimen from it, why don't we use the same system to deliver treatment, whether it's nanoparticles, energy, gland-specific chemo, whatever. And he's like, here's $30,000 in 3 months, go figure it out. So I made a long list for my engineers of what doesn't work. There are certain things that you just can't bring in an MRI. Like if I brought your chair in the MR scanner, it would fly across the room and hurt somebody. There are certain things that just don't work in MR. The two things that did work in MR were cryotherapy and laser. And when I made a matrix of the attributes and drawbacks of each of those energy sources, and I've done this with all energy sources, the thing that showed the most precision and controllability to me as a scientist was the laser. It had been used in the brains of children with intractable epilepsy. So instead of doing a full-on craniotomy on these kids to go in and get the tumor focus out of their temporal lobe, they drill a burr hole in the skull and advance the fiber under MR guidance and then burn the tumor away. So my thinking was that this thing is safe enough to put in the brain of a child, we could pop it through the rectal wall and treat the prostate. Now, University of Chicago, University of Toronto, and University of Colorado were already doing this, but what they were doing was going through the crotch. They were going transperineally and using temperature probes and doing the treatments through that route. And I'm like, why not go transrectally? And a couple people thought, yeah, that's interesting, let's talk about it. And I had some agreements in place and some negotiations going on at some academic institutions. But the way I was looking at this, it was like, if the perineal guys are already, 3-4 years into it and they've done 12 patients, I want to be able to get to 6 months and figure out the safety and feasibility of the transrectal route, and I want to do it in 6 months. So I didn't want to spend 6 months negotiating, I want to spend 6 months working. So I contacted a couple different institutions, and Desert Medical Imaging was an outpatient imaging center with an urgent care right adjacent to it. And Dr. Feller and Dr. May had done the most in-bore MR-guided biopsies in the world at that time. So I thought, who better to convert this from a biopsy system to a therapy delivery system? And they said, bring it on. So I did. So here's the FDA clearances associated with this device. This is one of the other fibers that I use. It's a non-cooled laser. This is the laser in a chicken breast with the sheath pulled back so that you can see the fiber and what it's about to do. This is about 1.5 minutes into a treatment on a chicken breast where you can see the thermal map, the anatomic image, and the irreversible damage estimate, as well as the temperature graph and assignment of temperature per region. And then after I did it, I dissected it so that I could measure what the size of the kill zone was compared to what the estimate was. And this is the team that I worked on that project with. That's Dr. Feller, Mrs. Thomas, and Mrs. Allen. And one of the things that I stress to people, and I had given Ethan some photographs of some textbook chapters that I either wrote, contributed to, or used as the basis of a lot of my research. Everything that we do is at 1.5T or less. You've got people marching around the planet going, oh, 3T, 3T. 2 Tylenol is good for you, but 30 will kill you. I'm not saying a 3T is going to kill you, but when you look at the number of MRI scanners in the United States in 2013, and believe me, nobody's buying 3T magnets in this market right now. Everybody's conserving and not buying anything. So I think the number is actually higher, 1.5T systems, and then the remainder are less than 1.5T. So when I serve on the PIRADS committee, we're trying to make sure that anybody performing prostate MRI at all is doing it properly, and they're doing it at whatever field strength. If they do it at 3T, yeah, you might get the scan done 5 seconds quicker than if it's at 1.5T. But I was telling Jim and Ethan that I could do great imaging at 3T, or I could do lousy imaging at 3T. The things that matter way more than field strength are the skill of the operator. If you don't have a credentialed tech, there were people who grandfathered into being MRI technologists who were truck drivers. Okay, and if you don't understand the physics of image generation, you're not going to be able to make pretty pictures. The software has to be state-of-the-art and able to achieve high B values. The coils that we use need to be high channel count. I'm not a fan of endorectal coils because I have a lot of patients with no rectum. So if I have to develop a protocol that's really good and high resolution for a guy with no rectum, why not just use that protocol on everybody so we don't have to violate them with an endorectal coil? I could have the argument with people all day long. Patient preparation, nothing by mouth after midnight before your MRI. I get these calls all the time. Oh, I've got a patient, we want to send him over straight away. He's got a really high PSA, I want an MRI right now. Well, the guy had an egg burrito for breakfast. You're going to get a lousy image. The guy's got to be NPO and, not peristaltic. So there's a hormone called glucagon that our body makes that we can also inject to minimize the amount of peristalsis in the gut. So when we do the imaging, they're not blurry. And then, of course, the last thing is you need an experienced radiologist. If you've got a newbie in there, you're going to have a difficult time figuring out what's going on. So here's an example of 3T versus 1.5T. This is with an endorectal coil, and the only thing that I can really see is like the posterior part of the peripheral zone. And that looks, no matter how much I adjust or try to window level, if I get this part of the gland to look okay, I lose this part. So this is 3T with an endorectal coil, and this is us on the same exact patient with a 1.5T surface coil.
And what made the difference between the quality of those two images?
The fact that we didn't have an endorectal coil occupying the rectum, and that we used a surface coil that has even energy distribution throughout the volumes being imaged.
Okay.
So there's something called SCIC, surface coil intensity correction, that a lot of the MR scanners make to try to make up for this problem. You shouldn't have to have software to make up for a problem. You should just get a good image from the get-go. And then again, this is 1.5 Tesla. You can see it down here. And this is 3 Tesla, same patient. And you notice the kind of blurry arcs here, and you don't get the same detail that you have here. Like this part of the gland shows the tumor, you could like barely see it there. So, you know, I could have a cerebral discussion. Go ahead.
How much of that is related to the experience of the operator and the software?
A lot. A lot.
Okay, so how do you control that?
You call the place up and you ask them, do you do prostate MRI? And if they say yes, you ask them, are you applying for ACR accreditation? Does your technologist have certification to be performing these studies? How long have you been doing them? How many have you done? So if you ask how many they've done and it's in the thousands, you can pretty much be reassured that they know what the heck they're doing.
Is there an overall agency that's doing accreditation on
Yes.
those?
The American College of Radiology, and I serve on their accreditation
Is it
committee.
national or state?
National.
Okay.
Yep. It's the American College of Radiology, and their current guidelines are called the PIRADS guidelines, and that's what people rely on to tell them, you know, not only how they should be doing the scan, but how they should be calling findings.
That was one of those first slides you had.
Right, and that's a common lexicon that all radiologists in the country and in the world should be using to describe what it is they see. So no matter if I get a case that comes into me from Canada, go ahead.
One more question. After you have one radiologist take a look at those slides and come up with a determination or an analysis, do you have a second radiologist confirm it?
No, it's not typical to overread anything. If it's a learning institution, you may have a resident look at it the first time and then faculty look at it a second time. But in normal practice, either you've got an expert looking at it or you don't.
Okay.
So we talked about the scanner parameters. There's all this stuff on the screen that you get to pick from when you set up the imaging protocol. And this is to your question, sir, the rainbow shirt. This is where we would put that no fold over on to make sure that stuff from outside the field of view doesn't wrap into the picture. There are things that we use to exploit tissue contrast, flow quantification, blood perfusion, cellular diffusion, and phase shifts. And these parameters that we manipulate are many: epitime, repetition, flip angle, bandwidth, signal average, matrix. All this stuff has to get programmed in there to make the picture. The good news is the energy that we get back to make the picture can also be mathematically altered to create temperature maps. So we're able to real-time view thermometry and predict temperature change along a gradient, which is how we do the laser thermal therapy. So while I can contour to what it is I want to kill, I'm also able to put little safety cursors over what I don't want to kill. So if the temperature exceeds a preset threshold in things like the rectal wall or the urethra or the neurovascular bundles responsible for erection, the system shuts off automatically with no user interaction. And we do it that way on purpose because we want to get a good burn in the thing that we want to destroy, but we want to protect the things that we don't want to harm. And so here's an example of contouring to this long oval thing and then putting little safety cursors over the neurovascular bundles. And then somebody asked me earlier, how do you do a laser on a guy post-prostatectomy? If the prostate's gone, what are you treating? Often what happens is that the surgical anastomosis, where they reconnect the urethra into the bladder, that's the most common site of recurrence post-prostatectomy. So if a guy who's had his prostate out has a PSA that's going up, what do you think's going on? He's got recurrence. Because if your prostate's gone, the PSA should be 0 or undetectable. Sometimes they'll leave the seminal vesicles behind, sometimes they don't get a clean margin, and what will happen is the cells proliferate and it grows back. So if you can make sure that the guy doesn't have bone mets or lymph node mets, and we could see it, we could treat it. So there it is before and there it is after. And so I tweeted this back on April 5th. And so when we talk about what fiber we're going to use, during tumor board, we agreed we're going to use a little tiny fiber on this guy because this thing's sitting just against the rectal wall. So we did something called hydrodissection, where you inject numbing medicine into the space between the lesion and the rectal wall, so that builds distance. So you see how thick the distance is between the rectal wall and the area that we ablated? That's because we injected the Marcaid there. And so we do a little bitty test dose just to get some energy in the area so we could see it and make sure we're in the right spot. And then once we confirm we're in the right spot, we start cooking. And This is the first time I ever talked about this, was in 2011 at the European Congress of Radiology. So this isn't like rocket science or something brand new. You know, when people go, oh, I don't know about that. Well, open a journal, go to a conference, maybe you'll learn about it. And this is a case study that I can share with you. This guy had Gleason 3+4=7. It was in the left transition zone. We burned a nice big hole in it, and we try to always get a good margin around 1 centimeter around it to make sure that anything that may be interdigitated or surrounding the main tumor, we want to get it all. And then there's a side view of it, looking at him from this direction. We got a nice tall burn there. And then he came back per protocol at a 6-month follow-up, and we did a biopsy sweep of the treatment area, taking 3 or 4 cores out to treated spot, and he had a negative biopsy, which is good for him. So remember I said I did a little matrix comparing different energy sources, what might work, what might not work? Remember where my head was at back then. I wanted to prove that it didn't work, because if I was going to do some recommendation about a merger or acquisition or procuring equipment or dedicating resources to a thing, I wanted to make sure that it worked. And how you prove that a thing works, you try to make it not work. Not like on purpose, but you evaluate it critically. So I compared laser to cryo and HIFU and RF. And what you'll notice is that these transition zones between treated and untreated tissue are very wide, very fluffy. So if this is an aggressive tumor and it's got little bits of it out here, I'm a little worried that maybe we didn't get it, so then you've got to go even bigger with your margin. Same here for RF and cryo, but then look at this nice, crisp, thin transition zone with laser. So that was one of the other attributes that I viewed very favorably. Now this is from last quarter. We've got now 130 patients and 180 treatments. So back then, this was 119 patients. The number of treatment naive guys, meaning guys who had never had anything, was 100. And the guys who had been radiated or had brachy or prostatectomy, there were 19 of them. We had a total of 175 lesions. The mean initial PSA was 7.31, higher in the salvage guys because they tend to present with a higher PSA in the beginning. The youngest man that we treated was 48 and the oldest man was 87. So this is an institutional review board approved study. There's a study number. We use a 15-watt 980 nanometer diode laser and a 1.5T system. And what's important to know is many of the devices that we use are FDA cleared up to 1.5T. So here's another argument against 3T. Anything bad at 1.5T is going to be worse at 3T, and many of the instruments that we use aren't even FDA cleared at 3T. We consider it to be true focal therapy. In other words, anybody could shove a laser fiber in a thing and burn the whole thing. You know, that's not focal therapy, that's whole gland therapy. We do 6-month biopsies as a matter of course as part of the protocol, and then we do 1-year imaging, and we watch the guys for 20 years. We look for elevation of PSA density, which is the PSA divided by the gland volume. That's a really important number. PSA in a vacuum isn't always super helpful. Serial PSA is helpful, and serial PSA density is also very helpful. We also look at International Prostate Symptom Score, which is a benchmark for urologic function. How's he peeing? Sexual health inventory. Is he able to attain and maintain an erection? And PHQ-9. We also recently added the NCCN distress thermometer, the PHQ-9. This is a personal health questionnaire. It talks about how emotionally distressed are you right now, and we track emotional health as well as physical
You
well-being.
may have said it, but I couldn't hear. What's a naive patient and a salvage patient?
A treatment-naive patient's never had any treatment for his prostate cancer ever.
And salvage?
A salvage patient has had a treatment and it failed. But the only time we would treat a salvage patient is if we have a PET CT that shows no lymph node mets and no bone mets. So again, we don't want to treat people who have no business being treated. And any guy who presents with metastasis has no business getting focal therapy. Now, could that be another study? Could it be another study to determine if in the natural history of this guy's disease, if we blast the primary local recurrence and treat, will that have any impact on survival? I don't know. Maybe down the road we can figure that out, but I'm not focused on that right now. So the tumor location statistics, Mostly in the peripheral zone, a bunch in the transition zone, less in the central zone, and we've done some salvage treatments in the bladder wall and the subtle vesicles. Gleason score breakdown for all of our patients. The predominant Gleason score that we treat is 3 + 4 = 7. We also do high volume 3 + 3 = 6. We also do 4 + 3 in the treatment naive setting. In the salvage setting, we do all comers as long as, again, they have no bone mets or lymph node mets. And I like this slide because there are people out there that, for whatever reason, I don't know why they attack us. It's the strangest thing. Like, we're doing a clinical trial and we're collecting data to give men an alternative to whole gland therapy. So you can imagine there are people that may not like us because they want to either do surgery or radiation. And if we're doing this, they're not getting their opportunity to do what they do. And one person actually said, "Oh, well, all you guys do is 3 + 3, so how can you say?" And that's not true at all. We do high volume 3 + 3. If you can see it on MRI and you can treat it, it meets the inclusion criteria for the study.
All right.
Yes.
We had somebody from ProScan then who come in who's doing the prostate MRIs, a lot of them. And he says, 3 + 3s don't really show up.
Remember I talked to you about the pepper shaker?
Yeah,
The flaky ones won't show up,
right,
but the peppercorns will.
right, but his idea was,
We don't want to see it.
we don't want to see that
Right.
one, because you want to see
Exactly.
the ones that are going to do the damage.
But if it is 3 + 3 and you can see it, you probably should treat it. So that's the distinguishing factor.
With
Yeah.
respect to the 10, was that an accident that you took, that small group 1.1%, or is there just not that many to
It's
choose
not that many.
from?
This man who was the Gleason 10, he also had Gleason 9. The 10 was in his bladder wall, the 9 was in his seminal vesicle, and the 7 was locally recurrent.
But you intended to have him in the study, this was not an accident?
Absolutely,
Okay.
yeah,
But there just aren't that many with 10 because
Right.
there's such a small percentage.
right.
Well, okay, mine was a 10, okay, and I had a prostatectomy, luckily it was 10. Normally, if it's not a salvage thing, you wouldn't want to do a focal therapy.
Absolutely not, right. So,
Okay,
have we ever done a Gleason 9 or a Gleason 8? Yes, off protocol. And they were physicians. And they came to us and said, either you're going to do me or I'm going somewhere else. And we had them sign an attestation that they understood that there was a clinical trial using this technology, that they don't meet the inclusion criteria, but they're willing to assume the risks and responsibilities of using this option, and that they know that there are other whole gland treatments available to them. And if it were a lay person, we probably wouldn't have done it, but because it was doctors, they knew what they were getting themselves into.
And in the case of all these, none of them had metastasized, correct?
I have one patient that got bone mets, we'll get into that. So in the treatment naive group, again, mostly 3 + 4s. In the salvage group, mostly 3 + 4s, some 4 little potpourri of everything. This Kaplan-Meier curve shows the death rate, so we had no prostate-specific mortality. We had 2 patients pass away due to metastatic melanoma. So you guys that are worried about your prostate cancer, make sure you get your skin cancer exam.
Can you go back to that for a second?
Sure.
Okay. Probability of recurrence. So, in other words, you have had recurrences or the need for reablations.
Right.
So can you talk a little bit about that?
Yeah, so I'm going to get to that in just a second. So at 7 and 8 years, there was only one case of metastasis-free survival 99%, overall survival 98%, cancer-specific survival 100%. As I mentioned, the only men that died were victims of melanoma. So when we look at marginal recurrences, this is what I think you're asking about, Ethan. So of the patients who are done that have negative 6-month biopsy, they go on active surveillance. They're imaged at 1 year, their PSAs continue for 20 years or as long as they're alive. And we have a database or repository that we keep track of everybody. Now, when we look at marginal recurrences or residual disease, If it's 3+3, they go on active surveillance. If it's like 5% of a 1.8 cm core, we're not going to reablate that guy, especially if when it came to us with 4+3. If there's an itsy-bitsy smidgen of 3+3, the choice is, do you want to retreat it? Do you want to watch it on active surveillance? Or do you want to have whole blood therapy? And 99% of the time, it's let's watch it.
Can I ask a really quick question about that? So if you see something that's marked with PIRADS 2, but it shows up maybe on DCE, are you going to biopsy it? In other words, if you see it, are you going to biopsy it in this?
If it shows up on DCE, it would be biopsied and it would be a PIRADS 2. If it's showing up on DCE and the goal is to rule out recurrence, PIRADS isn't really a thing that we use for recurrence. PIRADS is for diagnosis, initial diagnosis. So that's two different populations of people. So the place where DCE is most helpful is in recurrence. Yes?
How do you deal with the issue of a salvage person or something, a high PSA or Gleason, that it may be metastatic?
They would have a PET CT, and if we saw negative PET CT, we'd go ahead and do it.
Prior to your,
Absolutely.
okay.
Yep. So either Axumin, gallium-68, DCF-PYL, any of the PSMA agents, or C11 acetate, any of those. So,
I'm sorry, just one quick question. So I don't know if you're going to be talking about this. You know, there are these two technologies, well, the three technologies that you mentioned, the T2 images, the diffusion-weighted images, and DCE, right?
and the ADC is a derivative of the DWI.
Yeah, right. So if something doesn't move the ADC numbers, but shows up in DCE, would you consider that clinically significant?
At diagnosis,
Say,
it would probably be a PIRADS 2 or 3, because if it's not showing up on diffusion, probably it's infection inflammation.
yeah.
Yeah.
But if somebody comes to you to a year after he's been ablated and something shows up,
That's
doesn't move,
different. That's not diagnostic. That's
Right.
post-treatment.
but in a
So we're
different
looking for
area,
recurrence.
even if it's in a different area, you wouldn't consider it to be an.
Post-treatment, if something moved it up, it would be biopsy,
Yeah.
for sure.
Mm.
So the one thing that we worry about is our whack-a-moles, what you just described. A guy comes in, he's been treated, he's clean at the biopsy, 6 months of the treated area, but he's got de novo cancer, brand new stuff, popping up all over the place. That guy's a whack-a-mole, and we don't dabble in that. If we see that there's multiple new lesions, we urge him to do something different. In terms of what happens with the PSA, we have a nice steep decline in PSA in the entire population. Post-treatment, mean PSA 38%. I think now that I've got more data, it's closer to 42%. So the conclusions, 8 years into this, over 100 patients were done with transrectal laser focal therapy. We proved that it's not only safe and feasible, but we're measuring biochemical recurrence, rates of metastasis, and all causes of death. Because in 20 years, I want to show a pie chart of the little bitty slice of pie showing these men died as a direct result of their prostate cancer, and all these other guys died of something else. So that's going to be our non-inferiority measure. No statistically significant erectile dysfunction or incontinence, which is beautiful, because when you consider, you just have a prostatectomy, yeah, you can, but you risk certain quality of life issues when you opt for prostatectomy over focal therapy. And we're not saying that this is for everybody. It's carefully selected, culled men. So obviously, the men who call me up and want to be considered for inclusion are people who want to preserve their erectile function and incontinence. With favorable quality of life measures, no significantly documented decline in sexual function or urinary continence. Short-term and intermediate-term oncologic control is achievable in 75% of patients. So, when you look at the rates of recurrence for brachy or radiation or surgery, we're better than them in most cases. So it's minimally invasive. It's in an outpatient setting. Nothing brings good results like follow-up. Dr. Feller likes to say that. That's why we're doing a 20-year phase 2 study. There is an international multi-institutional phase 2 trial for the International Laser Network. It has IRB approval. So I formed the International Laser Network about 5 years ago because I had taught 3 doctors on the planet how to do this. And I check the FDA MAUD database quarterly, and I look at who's got injuries, who's got side effects, and where deaths are occurring. And I research what made that happen, and I give it to my team, and we use it as a teaching opportunity. So if I see somebody got a rectal fistula, I investigate the circumstances under which that occurred, and we avoid it. And people talk about the Greenwood-Feller effect. It's not, again, rocket science. You know, I'm the lady that wrote the application requirement specification for pieces of the hardware and the software, so I'm a good person to have in the room. Dr. Feller did the most MR-guided biopsies in the world when we converted to a therapy delivery system. So he has the most experience in terms of runtime with this particular procedure. So we don't get the complications that other people get. And when people come to observe us, you know, they see that this thing takes 4 hours, and they're like, oh my gosh, it takes so long. It's precise, it's controllable. It may take 4 hours, but it's better than, you know, an 8-hour surgery. It's better than weeks of radiation. So walk in and walk out 4 hours later and have a 75% chance of success. That's not bad numbers. And every man in our salvage cohort is still alive. So
there's really no recovery issues?
take it easy for a few days and then ease back into normal activity over 3 to 4 weeks. And so getting back to the laser network, when I heard that people were getting injured, I formed a consortium. You guys just met me. I'm not going to walk up to you and go, hey, what do you think you're doing? I'm going to form a club, and I'm going to invite people to come to the table and talk about what do you do, how do you do it, who do you do it on, and what are your results. And if you can come to the table, you're welcome to the club. And so we meet every year, twice a year at the AUA and at the RSNA. And I abbreviated our 20-year study to a 5-year study. And there are 5 sites in the world that agreed to adhere to that protocol, and we're putting all our data into a common repository. So that's the international multi-center study. I'm also doing ongoing IRB-approved research exploring tissue genomics to risk stratify men considering focal therapy. What does that mean? So in our phase 1 group, I had over 100 guys. And there was this test that they used on whole mount histology called Decipher to determine if the guy who just had a prostatectomy needs radiation also. If he had a high-risk genomic profile, they would radiate him after surgery. So I'm super shy. I went to the founder of this technology about 4 years ago at the AUA, and I said, when are you going to offer this test on biopsy cores? And he goes, never. And I said, why not? And predictably, he said, because cores are crap. You know, I don't know where these came from, so why would I run an expensive genomic test on a random sample? And I said, what if I gave you gold? What if I gave you cores that were 1.8 cm, that were aimed at the lowest ADC of the tumor, and that had 20, 30, 40% tumor? Could you extract enough RNA to run the Decipher test on that tissue? He said, let me think about it. So fast forward to February of 2016, the test became available for cores. So I went backward in my research cohort, and I contacted all the men who would allow me to put them in the study, and I procured their pre-treatment cores, and we ran Decipher. So here I've got this spreadsheet on my wall that takes up my whole wall, and I've got all these Decipher scores on these guys. Remember the slide I showed you with the recurrences? So I know who those guys were, so I pulled them out, and I matched them to a buddy that was the same in terms of age within 5 years, Gleason score, and zonal anatomy. What I discovered in looking at genomic behaviors among and within those groups, the responders upregulated and downregulated 40 genes exactly the opposite of the non-responders. So we're looking at this panel of genes as sort of a binary yes, no. You should have focal therapy or you shouldn't have focal therapy. But the only way that we're going to be able to get there is to have years of data showing outcomes, long-term outcomes, in guys with certain genomic profiles and long-term outcomes in guys with other genomic profiles that don't do well. So that's an ongoing study. And then we have investigation of new drug submission for combination therapy that's awaiting approval.
I didn't hear you mention this, but is any of your treatment confounded by pre or post-treatment therapy, such as hormone therapy or chemotherapy?
Combined therapies. So talking about confounding in treatment-naive population, like I just took a call before I stood up here. This guy wants to go on testosterone, and it's like, no, do one thing. You can't evaluate a thing when you're throwing a bunch of other stuff at it. So that's in the treatment naive
So
population.
you excluded anybody that had some other therapy?
No, they would be considered salvage patients.
Okay.
So they're welcomed into the study, and we're happy to throw the kitchen sink at them. Hormones, laser, metformin, go crazy. The salvage group is very different. What we're doing for them is palliative and life extending, and what we're doing in the treatment naive group is we're getting them in the batter's box, and we're taking a good swing and trying to get this thing under control in a minimally invasive fashion. Does that make sense? So they're two very different populations. We have one other group of men, HIV positive guys. So when you think about what a surgery will do to a guy with HIV, I mean, that's a double whammy. And it's a twofer for us because we're able to do a minimally invasive treatment for the patient, but the care team is also exposed to less blood and other potential infectious material. So I mentioned the International Laser Network. I'm the founder and the vice president. Dr. Jürgen Futterer from Radboud University Nijmegen is the president. Sandy Guy from Toronto is the secretary, and Dr. Aitek Oto from University of Chicago is the treasurer. And my team consists of my medical director, Dr. John Feller, Dr. Stuart May, who I honor posthumously. He's no longer with us, and that's Dr. May right there. And Roger McNichols is the guy that invented the laser, and that's him, and he's no longer with us. Axel Winkle is the engineer that holds the patent for the hardware. Wes Jones is my tech extraordinaire. There's only one like him on the planet. Rob Toth is my PhD biostatistician out of Rutgers. And my professor at University of Edinburgh was Andrew Farrell. Elder Rayleigh provided me the Research Advocacy Network Scholarship a couple years ago. Vinnie Smith is a patient of mine who gave me a check for $250,000 to help pay for treatment for men who couldn't afford it. And I also thank the Army Women's Foundation Graduate Program Legacy Scholarship. There you have it. Yes, sir.
That's one of those brilliant presentations. I've been around here 16 years. I just think it was just wonderful.
Thank you, sir.
It's brilliant, but practically speaking, I'm on the street, somebody says, hey, young, you do this prostate stuff. I have a 6th Gleason or a 4th, 3 or 3, 4, and they want to do a biopsy. Where are we? You know, I think they do too many biopsies in America, they're saying.
Right.
So where does it all go? Like, what's the cost of one versus the other?
That's a great question. So one of the things I'm going to show you on my bibliography, you'll see a paper by DeRoige et al. Let's see. DeRoige. I hope I included it. Number 7. Prospective study of diagnostic accuracy, prostate cancer detection, transrectal biopsy, and MR-guided subsequent MR-guided biopsy men with previous. Okay, this guy, Martin DeRoige, he also wrote a cost-effectiveness paper, but it applied to Europe and the Netherlands. So I have a close colleague. The International Laser Network is all scientists and physicians, but we have a patient consortium, and there's a health actuary that's working with us to duplicate Martin DeRoige's European work in the United States. So what we have to do is we have to look at the cost of trust biopsy and the cost of misdiagnosis with trust biopsy, and then compare it to the benefit of inserting MR at the beginning, not at the end. See, one of the things when I first got into this, it drove me crazy, that we only insert imaging at the end. Okay, why aren't we doing imaging at the beginning and avoiding all the things that go with missing stuff? You know, so they talk about over-detection of insignificant disease and over-treatment of insignificant disease. Well, the reason insignificant disease is over-treated is because they know that there's something worse there that they missed. So it's really tricky, and it's very political, too. I shared with the gentleman up front, Upton Sinclair said you can't incentivize a man to understand that for which he's paid to not understand. So if you're doing trust biopsy all day long, and I show up as the problem solver, depending on your mindset and your heart, you're going to love me or hate me. We've got people all over the world that love us, that send us their patients. We give them the most in-depth information that we possibly can from every angle, whether it's PSA density, imaging, genomics, targeted biopsy, histology. We'll give them every piece of information that they possibly can have in front of them to make an informed decision. And oh, by the way, we talk about the other stuff, and we don't badmouth it either. If I get a guy who looks like he's got some bulge and extracapsular disease, yeah, we could treat it, we could create some periprostatic necrosis, but you may want to consider whole gland therapy, consider prostatectomy.
I'm still not, haven't made it clear to me. In Cincinnati, we have sauna and we have, I guess,
Right.
imaging. If there's 4,000 biopsies done a year here, or, and you can't do 4,000 MRIs like I don't imagine. So what?
We do it in Indian Wells.
Yeah, but I'm talking about Cincinnati now. Every guy, doctor says, oh, your PS is high, we want to do a biopsy. Now,
Right.
what do we tell that person? What do we suggest
Well-
to a person, practically speaking, in today's environment in Cincinnati?
Do you remember the NCCN guideline that I showed you? That said MRI prior to biopsy will maximize the detection of clinically significant disease and minimize the detection of indolent disease. Some payers are of the position that, no, we're not going to pay for an MRI until we have a negative trust. I have no control over that. I have no control over what CMS does. We do what we do, and if insurance covers it, great. If there's a cost back to the patient, that's unfortunate, but at some point, they'll wake up and they'll understand. And when you look at litigation among prostate cancer patients, I am on faculty at UC Riverside School of Medicine, Department of Internal Medicine. So I work with internal medicine residents, and I share with them a paper that talks about litigation and where the plaintiffs prevail. And it's always when the PSA is not communicated, when an elevated PSA isn't followed. Those are the top two reasons. And then in the chart of where physicians are getting sued, not ordering a prostate MRI is number 13 on the list.
Is the answer, if insurance will pay for it, always get an MRI? That's what I hear you saying.
I would say
That
so.
should be the gold standard, you're saying, and it has to be accepted in our medical society in the United States, I guess. Is that what you're saying? And the insurance company to accept that?
What I'm saying is, what the guideline states, that MRI before biopsy can maximize detection of high-risk disease and limit detection of low-risk disease. Now, remember, there's a community of urologists out there that have done trust biopsy for 30 years. To put this in front of them and tell them they have to pitch the patient over to radiology, it's about ownership of the life, ownership of the patient. So I always said, we don't need to hold hands and sing Kumbaya. I am not a medical doctor, I'm a clinician scientist, so I can't give medical advice. But I tell patients when they come to consult with me, I open up the NCCN guidelines, I talk about everything that's available. I give them names of doctors in their area that they can talk to get as much information as possible. But, this may not be for everyone, it may be for some people.
Who's the go-to person in the city that you're saying, Dr. Verma? Is the
Dr.
go-to
Berman,
person?
absolutely.
Dr. Verma. How
Simon.
many can they handle what you see during the weekday?
That's a good question for them. I wouldn't know because we're not affiliated,
I'll turn the lights on.
but we do prostate imaging all day, every day, even on Saturdays.
Because the local ProScan imaging, he also said that that's what should be going on,
Right.
because if he can detect the tumor
Yeah.
without the biopsy,
Okay.
then
But I would caution you with that. You cannot tell a tumor without a biopsy. Remember,
right, but
there's-
you have a very good suspicion.
Right.
If it doesn't, if you can't see
In
anything
a
on
tumor
there,
suspicious region.
right,
Yep.
if you can't see anything on a well-done MRI,
Right.
there's no good reason to go in with a
Right.
biopsy. That's
Right,
all I'm
unless
saying.
the PSA remains elevated, and if they go on empiric antibiotic therapy and it's not prostatitis, then, maybe you're gonna wanna do a trust. Because remember, 3 to 8% can't be seen.
Can I ask to go back to that chart where you showed how much the PSA goes down post FLA? So there you go. Okay. So typically, if you do a focal therapy on a prostate, you still have most of your prostate, right?
Right, as long as you have a prostate, you will make a PSA.
Right.
That's why PSA density is important. So imagine a guy with a prostate the size of a grapefruit. And now imagine a guy with a prostate the size of an apricot, and they both have a PSA of 5. I'm not worried about the grapefruit guy. His PSA density is going to be very low because of his large gland volume, and it's probably BPH or something else driving the PSA up. The dude with the apricot with 4, we're going to want to image him and see what's cooking.
Yeah, but PSA values around 4 are still, you know, if I remember correctly from the studies, if you took a sample of men, right, 80% of them will have PSA less than 1.6, right? So if you've got some guy with a PSA of 4, doesn't that worry you? I mean, it's like,
Yeah, so there's inclusion criteria for the study that it's not PSA based, it's PSA density based. I have a guy, he presented, he was our 48-year-old, he had a PSA of less than 1. A billionaire who would go to Germany and Europe and get stuff done that isn't available here. And he had a whole body diffusion scan done 5 years ago or something.
how much does that cost?
A lot, thousands, I'm sure.
Yeah.
But he flew over in his private jet, which is fine. Some people can do that. But he ended up with what looked like local disease. So we MR'd him, biopsied him, and treated him. And his PSA was less than 1. So I wish I had,
Isn't that indication that he has a high-grade tumor?
not necessarily.
What's called PSA leak?
Not necessarily. I've got guys that run the gamut in terms of PSA values. Some guys with super high PSA that have 3+3. Some guys with super low PSA that have 4+3. It has to do with many things. It's multifactorial, it's vascularity, it's genomics, it's immunosuppressive ability, it's concurrent BPH and prostatitis with the tumor, which is important. Why sometimes what we'll do is if the guy has a high PSA and we can't see anything, put him on antibiotics. And what that's like is like taking a snowman out of the blizzard. Because if I've got a snowman and I've got snow flying all over and it's a bad blizzard, I can't see the snowman. But once I take that snowman out of the blizzard and I get rid of the prostatitis, the cancer's going to sit there like a sore thumb. So if you wonder why the course of events goes the way that it does, that's why. Yes?
With your comments about PSA density, are there any charts or something? I mean, take some numbers as an example. You say a 65-year-old man who's got a prostate the size of, let's say, 50 grams. I guess that's what you're talking about, the size of the prostate. And his PSA reading is 3.
I'm thinking the number for PSA density that makes people nervous is like 0.15, 0.2. You start getting nervous. We don't let anybody in our study that's 0.375 or higher. So I'm going to show you, I guess I can't show you.
So it's PSA divided by grams
Correct, cc.
equals the density. And you're saying that somebody is 0.2, that's something that...
I start getting a little bit worried. So Sworngeristos is the author. You could find it on PubMed or you could just Google it. The author's last name is S like Sierra, F like Frank, O-U-R-G-A-R-I-S like Sierra, T-O-S. And this was published in 2012, and he said there's a significant difference in PSA density values between patients with prostate-specific mortality, seminal vesicle invasion, and lymph node involvement. So that's where Axeman comes in and these other radionuclides. So if I've got a guy that's got a high PSA density and he wants to be treated and he's salvaged, I'd say get Axeman or gallium-68, make sure there's nothing cooking elsewhere.
Could you spell that name again? That sounds...
The name?
Yeah, well, or whatever, yeah. I guess it wasn't the name.
S like Sierra, F like Foxtrot, O, U, N like November, G, A, R, I, S like Sierra, T, O, S. This is
That's a man's name or...
I don't know if it's a man or a woman, but this is the individual that published a paper called PSA density is superior than PSA and Gleason score for adverse pathologic features predictions in patients with clinically localized prostate cancer. So I guess it's a guy, his name is Stavros Sworngeristos. And it's a really good paper. It's not geared towards lay people, so I hope it doesn't raise more questions than it answers. But the conclusion is, although PSA density is a preoperative tool derived by the calculation of prostate dimensions during truss, and the present study has a retrospective design and estimate of preoperative prostate volume was impossible. For this reason, postoperative information was used, in other words, whole arm histology. Studies have compared preoperative and postoperative prostate volume calculation. There's a strong correlation between the two methods, reaching or even overcoming 90%, which shows the estimation of prostate volume postoperatively by using prostate ellipsoid formula is reliable with minimal deviation from transrectal ultrasound results. So we're talking about the method by which they did the measurements. But it's clear that, prostate adverse pathology is better predicted when PSA density is put into the nomogram.
Okay, I've got another one for you. For somebody who's had FLA, right, or for that matter, any other focal treatment, what is the follow-up? I mean, well, let me pose it a little bit more pointedly. Today, if you haven't had treatment, if you're being in the diagnosis stage, right, now there are all these urine and blood tests that can be predictive. 4K score, PCA3, there's a whole bunch of them, half a dozen of them.
Yep.
Which are considered, now people are starting to consider this to be helpful. I actually turned to one of the guys who was promoting one of these tests and I asked him, well, why don't you do that for people who are post-treatment, like post-focal treatment? We're not supposed to have any cancer left, right? So why
Right.
can't we use 4K?
A lot of the diagnostic tests are diagnostic. In other words, they're there to diagnose, not for follow-up. So even when we submit pathology on our post-treatment patients, we don't run genomics on them because they're treated. So you're altering the landscape of the disease. So that may be one of the reasons. And all of them are like on the order of $1,500 to $3,000. So I think a lot of payers aren't going to pay for it. And then it becomes the patient decision, do I want to add financial toxicity to an already distressing situation?
So if I can follow up then, so is there a standard follow-up protocol which you agreed on with Federer and with Otto and all these other people who are doing LITT?
So there's a Delphi consensus panel that we created, and the manuscript is in press right now. So that'll be forthcoming in publication.
So you can't say more about that?
I mean, basically, it's, you can't treat and run. So there are people on this planet that will do the treatment and ignore the patient, and that's not appropriate. There has to be follow-up, and it's got to be rigorous, it's got to be auditable, it's got to be documented, it's got to be accessible. So that's the agreement. So, and the intervals of follow-up are going to be 2-day ultrasound of bladder, 3-month surveys of PSA, 6-month imaging, biopsy, and surveys, 1-year imaging, then periodic PSA and imaging is indicated, 2-year MRI, 2-year biopsy, and then watch it for 20 years. I mean, that's got to be the way that it's done, and we're the only people on the planet doing it that way.
Right. And what about PSA doubling time? So let's say you've got a patient who's had treatment 3 years ago and the PSA is rising very gradually. How do you approach that?
It's less about PSA doubling time and more about increase above the nadir. So let's say a guy comes in, his PSA is 6. We treat him and it goes to 3. And it goes 3.2, 3, 3.5, 3.1, 4, 3.3. It's going to happen. If you ride a bike or have intercourse or do prostate massage, there's all these weird things that'll make a PSA go all over the place. Also including inflammation and infection. 2 full points above the nadir, which is the low level it reaches post-treatment, which in this guy's case is 3. If his PSA goes to 5, that's when we would insert imaging and an indicated biopsy.
Okay, thank you.
The other question?
Well, I've got another one for you. When will insurance start to pay for LITT?
So I always tell people my feet are still purple, we can't drink the wine. So CMS likes to see 15, 20-year outcomes to prove non-inferiority. I had a meeting with the FDA talking about our 8-year interim results. Because prostate cancer is so slow growing, we have to prove what we need to prove, and we can't fast forward it. We just gotta let time go by.
Yeah.
So, and that's why anytime anybody asks me what they can do to help, I say contribute to the Focal Therapy Foundation, because that's how I get guys treatment paid for, if they can't afford it themselves. If they don't have a rider on their policy, I have 2 guys. One worked for the phone company, I think the other was a teacher. They had cancer riders on the policies, and they got it paid for. So, and because this is a clinical trial, it's considered experimental. What we've done is we've taken FDA-cleared products for soft tissue necrotization, not indicated for cancer treatment, indicated for soft tissue necrotization, and we've taken a biopsy system that's FDA-cleared for the purpose of in-hole prostate biopsy. We combine 4 different things to do the methodology that we do, and there is no CPT code for it. It doesn't exist because it existed here. And there's a patent pending on it, and I know it's impotent. I know it's not so I can be rich or famous or anything. It's so that I can claim, when I got somebody else on the planet saying that they pioneered this or that they invented this, it sits very wrong with me. So I'm more than happy to pay whatever I have to pay to get a patent on it, because we all know where it began. And it's going to go where it's going to go. The insurance payers likely will pay for it, because look, they pay for cryo, don't they?
Yeah.
Thank you. And when you look at the accuracy, the controllability, and the precision of these 2 energy sources, it's not even comparable. Not even comparable. And when I hear cryo people saying, oh yeah, we'll get your neurovascular bundles while we're in there, like it's a feature. No, that's the goal, is to avoid damage to important stuff.
Sure.
When is the nadir of the PSA reading normally reached? Or does the answer to that depend on the type of treatment you have?
I can only speak to what I've observed in our cohort, because that's the only one I'm studying. And what I observe is at 3 months, sometimes it can go up, because we just blasted a hole in the gland. So it's angry and the PSA may rise. But by 6 to 12 months, it should level out.
Good, okay.
Anything else?
Can we get this presentation?
I do believe you have it.
We
Yeah.
do? Where would that be?
I'm driving for it, so I'll put it online.
Yeah, and I don't mind sharing for teaching and stuff, no problem.
Yeah, I don't care about the words,
Get them
but
for your
the
personal
slides
use.
is.
Well, we'll definitely have that. Yeah.
Okay. I'm sorry, I'm from Kentucky, you talk very fast.
Oh, sorry, I'm from Connecticut.
I know, I can tell that. But I'm also new to this whole thing, so
Okay,
I was having a little bit of trouble staying with
no problem. If there's anything else that you want to know about, you've got my email address and my phone number.
Who's a prospect to come out and see you, come out to your study? Will we have people here that we ought to be referring out to you potentially?
It depends. So to enter the study is $25,000. That includes the treatment on treatment day, the 72 to 96 hour ultrasound, 3-month follow-up, 6-month follow-up, 1-year follow-up, 2-year imaging and biopsy, if you agree to also be in the International Laser Network 5-year abbreviated study. So there would be 2 consents. So any guy that feels this is right for him, give my number, I'm happy to talk to him. And this is an educational session, not a recruitment session. I just want you guys to know my goals here to inform you, not to recruit you.
But an insurance company would not cover this as long
No.
as it's in a stage.
No.
Between all the practitioners who have been doing LITT, and I think there are probably, I know there are at least 3, 4, 5 in this country.
University of Chicago,
Yeah.
Mayo Clinic, Desert Medical Imaging, Private Place in Houston, UTMB,
Yeah.
Emory University,
Sperling.
Sperling, Radboud University, Nijmegen, University of Toronto, NIH, UCLA.
Right, okay, so it doesn't say anything,
But-
doesn't.
11, but what we have to do is make a pie chart and look at who's doing it transrectally and who's doing it transperineally,
Okay,
because there's 2 different approaches.
okay. So how many LITTs have been done by
That's a
this?
great question. I only know my numbers because I share my data. There are people that don't share their data, so there's no way to say.
Yeah, isn't that an important thing? I mean,
I think it is.
yeah. I mean, I know that Walzer has done about 300. would you say, would be 11 times 300? I mean,
No, I've got sites that have only done 12,
okay.
yeah. And Toronto, I'm not sure how many they've done. I think Colorado did the first few and then stopped doing them.
Mm.
And a lot of these guys, you know, they're urologists and they'll start with one energy source and then jump to another energy source. You know, their goal was to put 4 guys on the books. You saw that text chapter? Did you see the table in there that I sent to
Oh,
you?
I'm sorry, I haven't seen it yet.
So there's a table in there that talks about Chicago, Colorado, and Toronto, and how many they did. 1 patient, 4 patients, 9 patients, 12 patients, 3 patients,
Yeah.
and all transperineal, and then a column with the morbidity. So you figure, you know, they did a few, they had poor oncologic control, they hurt a bunch of guys, and then they stopped doing it.
Right, well, that's not really cricket, is it? Because there is a learning curve,
Of
like
course.
with anything.
Of course.
But when can we expect to see some published results, some, you know, some studies that have actually been published?
That's a great question for everybody. Yeah, our manuscript, we've got 3 manuscripts in press right now. I think Herb Lepore out of NYU published some of his work with Sperling from early on. It wasn't anything we didn't already know. It's safe, it's feasible. We achieve oncologic control 75-ish% of the time. So, yep. And I don't know if we're going to submit to, I can't say what journal we're going to submit to, but I have our phase 1 results drafted and in the hands of our biostatistician, and I also have our phase 2 results and the Delta consensus. So those 3 papers are going forward.
Yeah. And now that it's been around for, 8 years or so, what kind of innovation is going on in this area? Is there anything that you're doing better today than you were doing 8 years ago?
Yeah, I think when we look at what was going on 8 years ago, it was true focal. We want to get rid of the MR visible abnormality. And when we saw around like a 35% recurrence rate, that was too high. We didn't want to go whole gland or heavy gland, so we began increasing the margins a little bit, and we're using a variety of different fiber sizes. So, and then there's also things we've done with the anesthetic to make it a really bearable procedure. We do something called the Mount Everest technique, which is that injection of Marcaine on both sides of the gland to numb it up. So we use less conscious sedation. The guy's wide awake the whole time, and we just numb the gland up, and we put some jelly per rectum to numb things up on the rectal wall.
Okay.
So, you know, over years, there's been refinement of what we do, and so when I first was going around showing people how to do it, me and Roger would go, because he was the laser dude and I was the aimer. You know, I did the software and the hardware for aiming, and he did the burning, so we were a good pair to have. The goal back then was just basic, you know, how does the energy work, how do you place things, how do you monitor what's happening, how do you document what they did, right? But then when we look at what we do, I roll out the red carpet and have people come observe. I have them sit through informed consent. That's a 1-hour-long process where I talk to the patient about what's happening. They've already read it. I've been talking to them usually for anywhere between 3 weeks and 3 months before I see their face. Then they get prepped. They get a physical exam from our nurse. We have certain drugs that we use that we prefer. There's the positioning, the choice of coil. There's taping and placement and anchoring of devices. There's like secret sauce to it, you know what I mean? But over the years, we refine things to where our team, everybody knows their job, everyone does it well, and we get good results.
Yeah.
Do
Great.
you have questions, sir?
Just broad brush, what's the advantage, disadvantage of transrectal versus transperineal?
If you look at geometry, kind of the basics of geometry, a line from point A to point B, the longer it is, the more opportunity for skew. The
Right.
shorter the distance, the less opportunity for skew. When you go through the crotch, you're going through skin, subcutaneous fat, muscle fascia, sometimes the penile bulb, in order to get into the distance that you need to go to get in the thing that you're going after. And it's traumatic. It's needle insertions of a 13, 14 gauge device through the crotch, right? So going through the rectal wall is just so much simpler.
Okay, all right, thank you.
About going through the rectal wall, so a few years ago, I was reading some article about infection rates.
Antibiotic resistant
Yeah, so
bacteria.
they're saying, roughly 3%. And yesterday I was reading an article that's saying infection rates today about 5 to 7%. So like
Yeah.
they're doubling.
And that's for trust, because you've got multiple
Yes,
punctures,
that's
you've
for
got, yeah.
trust.
So
True.
remember I said that there was an inverse, that there was a direct linear relationship between increasing cores and hospital admissions and sepsis.
Sure.
So we do fewer cores with our biopsy system, and we use a broad spectrum antibiotic called Rocephin. There have been people who say, oh, we should do rectal swabs and, prescribe boutique antibiotics and do all this individually. No insurance company's going to pay for that, for guys to get rectal swabs. And our infection rate is less than 1%.
But rectal, I mean, I know that in Europe they use rectal swabs as standard of care. Why not? Is that expensive?
I don't know. Everybody I've ever talked to about it said, nope, not going to happen in the United States. The goal is to give IV systemic antibiotics at the time of the procedure, assume everything's going to be okay, and 99.99% of the time it is. If the guy spikes a fever within 24 hours, you get him back and you give him something else.
Okay. And what was the name of the
Rocephin?
Rocephin?
Yep.
And so that's better than Cipro in your
Yes. Cipro has some associated tendinosis and tendon tearing issues. Yeah, so we got away from that about a year and a half, 2 years ago.
We'll make Ethan our conduit here.
Right.
We'll let him study it, we can put it down to our lands.
And so
He and
the,
Soderbergh will take care of us, then we'll come out to see you.
all right.
Well,
So here's
fine.
that paper that I talked about. I put it up here so.
Okay. Great.